talk on diabetic retinopathy, see, this is the one. It's a microvascular ocular complication of the diabetes occurring in both type 1 type 2 diabetes, more in the type 1 diabetes. Affects the small vessels and the retina due to prolonged uncontrolled hyperglycemia. One of the important causes of the preventable blindness. So in India, there are two reasons for the preventable blindness. One is cataract, the second one is diabetic retinopathy. So there are the prevalent studies, classification, NPDR and the PDR. NPDR is divided into early, moderate, and the severe. So this is the normal retina. Your microaneurysms, hemorrhages, dot and blot hemorrhages, cotton wool spots, soft exudates, hard exudates, venous changes because of the dilatation, blotting, tortuosity. Sight-threatening diabetic retinopathy, diabetic macular edema, involvement of the fovea by edema, proliferative retinopathy, vitreal hemorrhage, pre-retinal hemorrhage, fractional attachment, detachment. So these are very little can be done in such cases. So I had uncontrolled diabetes for the 20 years. Fundus photograph. So this is the fundus. Symptoms usually asymptomatic. The factors that can worsen the diabetic retinopathy. Systemic, long duration of the diabetes. Again, control the diabetes very effectively. Poor glycemic control, hypertension, lipids, nephropathy, pregnancy, anemia. Other factors, posterior vitreous detachment, chorioretinopathy, and cataract surgery. Genetic factors. See, a word about the pregnancy. Suppose a type 1 diabetes people, pre-pregnancy counseling is very important. So in the pre-pregnancy counseling for all the type 1 diabetes, so get the retina test. If the retina shows proliferative diabetic retinopathy, she is unfit for the pregnancy. Okay? If the pregnancy is in the early months, so better to terminate the pregnancy. Otherwise, these people will have vision loss. So that is very important point in pregnancy, especially in the pre-gestational diabetes or in the type 1 diabetes getting the pregnancy. So pre-pregnancy counseling, one should screen for the retina. If it is non-proliferative diabetic retinopathy, go ahead, continue the pregnancy. If it is proliferative diabetic retinopathy, terminate the pregnancy. In all cases, detection of the retinal lesions at the initial screen warrants more frequent follow-up examinations. So this is the digital retina camera, laser therapy. Laser will act on the receptor layer, reduces the metabolic requirement, reduces the hypoxia, reduces the vasoformative factors, and reduces the neovascularization. See the before and after. Pan-retinal photocoagulation, treatment for the proliferative diabetic retinopathy. Complications of laser photography. These are rare, but occurs because of the pain, a transient central vision loss, choroidal effusion, field constrictions, vitreal hemorrhages, macular epiretinal membrane, reduced or compromised accommodation, mydriasis, etc. These are the anti-VEGF agents. Bevacizumab. So prevention is better than the cure. So here again the glycemic control. The root cause is diabetes. Blood pressure control, lipid control. So ABC. A1C control, B control, BP control, C means cholesterol control. Of course, cessation of the smoking. So these are non-retinal ocular manifestations of the diabetes, other than the retina. So conditions directly associated with the diabetes: cataract, anterior ischemic optic neuropathy, diabetic papillopathy, ocular movements disorder. Conditions for which diabetes is a known risk factor, like glaucoma and ocular ischemic syndrome. Conditions where diabetes is a possible risk factor: retinal artery occlusion, retinal emboli, retinal vein occlusion, and corneal disease. Often there is a delay in the detection of the diabetic retinopathy. That is true. Maybe because of the ignorance, maybe because of the lack of knowledge among the medical professionals, not to refer these cases to the ophthalmologist. So the lack of awareness in the patient that retina can be affected in the diabetes, lack of awareness in the doctor itself that retina can be affected in the diabetes, lack of symptoms like visual disturbances. Patients may mistake test for glasses as the retinal examination. Quite often diabetes and diabetic retinopathy are asymptomatic. Unless indicated by the physician, the patient may not undertake an eye checkup. Hence the importance of counseling for retina checkup once in every one year. So here the 54-year-old lady comes for the annual checkup. Type 2 diabetes and is an OHA and insulin. Fasting 118, good. PPG 184, okay. A1C 7.1, 7.2, so less than 6, 54 years ago, 6.5 and 6.6 is ideal. Blood pressure is 138 by 92, so ideal is less than 90 diastolic. Here diastolic is there. Retinal examination shows new vessel formation elsewhere. Other medications include ramipril, atorvastatin, and diazepam. What type of diabetic retinopathy is this patient suffering from? So neovascularization. What is the further line of the management? So these are the indications. Annual checkup, any degree of macular edema, any proliferative diabetic, severe non-proliferative. So that finishes our retinopathy. So in retinopathy, always refer the cases to retina surgeon. So definitely helps a lot to the patient because one of the important reason for preventable blindness. Now this is a very important topic, very common. In fact, the most common complication of the diabetes is diabetic neuropathy. Most common complication is diabetic neuropathy. And also most troublesome. And also secret complication. Hidden complication. Painful complication. More than 50% of all patients with diabetes at some time or other in their lifetime will have the diabetic neuropathy. Presence of symptoms and are signs of the peripheral nerve dysfunction in people with diabetes after the exclusion of the other causes. Diffuse neuropathy, mononeuropathy. Diffuse neuropathy is a distal symmetrical polyneuropathy, primarily small fiber neuropathy, large fiber neuropathy, or mixed small and the large fiber neuropathy is the most common one. So the symptoms also differs from the small fiber neuropathy and the large fiber neuropathy, but the mixed is the most common. In the same way, neuropathy, the vascular neuropathy and the pure neuropathy. In mononeuropathy, isolated cranial or the peripheral nerve neuropathies, that is also very common. Isolated sixth nerve palsy. Mononeuritis multiplex. Some people have the tingling numbness sensation or the lower chest or the posterior chest in a particular area of the skin. So they will have the neuropathic symptoms. Radiculopathy is also very common, especially lumbosacral polyradiculopathy or proximal motor amyotrophy. So they find difficulty in getting up from the sitting position. So weakness of the thigh muscles. Thoracic radiculopathy. Non-diabetic neuropathy is common in the diabetes because of the pressure palsies. Chronic inflammatory demyelinating polyneuropathy like your Guillain-Barré syndrome. Radiculoplexus neuropathy. Acute painful small fiber neuropathies. See the different neuropathies. So neuropathy means not the simple tingling and numbness sensation. So whether it's a small fiber or a large fiber or the distal or the proximal, is it a single nerve or the multiple nerves or radicular plexus neuropathies, etc. This is the very common. The most common is diffuse symmetrical polyneuropathy. A chronic sensory motor neuropathy. Symptoms are predominantly sensory symptoms. Glow and stalking pattern of the involvement of the feet, involvement of the hands. The symptoms like pain, the pricking, burning, or the lancinating in the nature, numbness of the area, and sensations on walking, sensation of walking on the cotton wool. Paresthesias are also common. Allodynia can occasionally occur. In later stages, the reduction of the pain and the gradual loss of the sensation. So once there is a reduction of the pain and the gradual loss of sensation, so that foot is going to have a chronic ulcers. So whenever they get for a trivial injury also, so they get the ulcers because of the lack of the pain and lack of the sensations. So that is the obvious side where we have to give very good protective footwear. So footwear is very important. Protective footwear is very important in all these chronic diabetics with distal symmetrical polyneuropathy individuals. So as I told you that small fibers are different from the large fibers. The small fibers, burning pain, lancinating pain, paresthesias, cutaneous hyperesthesias. When touch the feet, they get lot of the pain there. Loss of the pain and the temperature sensation later stages and ulcers. These are all the features of the small fibers if they are affected first. Large fibers, loss of the vibration, loss of the proprioception, loss of your reflexes, especially the ankle reflex, slowed nerve conduction velocity. If you send it for nerve conduction studies, that shows the report shows very slowed nerve conduction velocities. So that is mostly of the large fibers if they are affected first. See the small muscle wasting and also the deformities of the toes. The wasting and the deformities is all because of the motor neuropathy. Wasting of the interossei and the hammer toes. So these hammer toes again, there are pressure areas will be there, and they are there. These people will get a trivial injuries and then leads to the callus formations and then the foot ulcers. Deformities due to the motor neuropathy can develop the ulcers at the abnormal pressure points, which go unrecognized due to the loss of the pain sensation. These are the common neuropathies, mononeuropathies, cranial nerve, third nerve, fourth nerve, sixth and seventh nerves. Most common is the sixth nerve. In the thoracic areas, mononeuritis multiplex, they almost behave like a chest pain or the pleurisy or the pericarditis like picture. In the peripheral, the lateral cutaneous nerve of the thigh, peroneal nerve, soral nerve, etc. So this is the comparison of the mononeuritis and entrapment neuropathy. Onset in mononeuritis is sudden. In entrapment, it is a gradual. Pain is acute in mononeuritis, a chronic and entrapment. Multiple nerves involved in the mononeuritis, whereas entrapments are rare. Course resolves by itself, mononeuritis mostly resolves by itself if you control the blood sugars very effectively. In the entrapment neuropathy, they persist without any interventions. Treatment is the physical therapy for the mononeuritis and entrapment neuropathies. Maybe the rest, splints, some surgeries, or maybe steroid injections in that particular areas. See, this is the third or cranial palsy. Sudden in onset. Maybe headache may be there. Pupils usually spared. Fibers supplying the pupil are outermost and hence less susceptible to the ischemia. Incomplete ptosis, hence diplopia may not be a prominent symptom. Full recovery is the rule, provided if you control the blood sugars effectively. So this is the sixth nerve palsy, presents with the diplopia. Inability to abduct the affected eye, abduction will be lost. Again, the full recovery is the rule if you control the blood sugars very effectively. See both the thighs. So in the right thigh, there is the wasting of the muscles there. So this is called proximal motor neuropathy. Acute or subacute onset of the severe neuropathic pain, wasting and weakness of the quadriceps, loss of the knee jerk. It is usually unilateral. Multifocal involvement of the lumbosacral roots, plexus and the femoral nerves. Usually recovers spontaneously. This is the hyperglycemic neuropathy. So the term itself says that it's all because of the high blood sugars. So the treatment is control the blood sugars, control the hyperglycemia to euglycemia. It's a reversible, found in poorly controlled diabetes. Uncomfortable sensory symptoms in the legs. Clears rapidly and controlling the sugars. Nerve conduction study shows a slowing of the nerve conduction velocity. This is very important, autonomic neuropathy. It could be a cause for a sudden cardiac death. So autonomic neuropathy of the different organs. CAN is cardiovascular autonomic neuropathy, and GAN is gastrointestinal autonomic neuropathy, and also you have the urogenital autonomic neuropathy, etc. In the cardiovascular CAN, you can have a resting tachycardia. So on the rest also the heart rate will be at 110, 120, 130. So that is autonomic neuropathy. Orthostatic hypotension, skin temperature reversal, dry skin, dependent edema. So these are cardiovascular features. Again, our people are having more of gastrointestinal autonomic neuropathy. That means vomitings, gastropathy, esophageal dysmotility, gastroparesis diabeticorum, constipation, diarrhea, alternate constipation, diarrhea. And some people will have the fecal incontinence. So these are all gastrointestinal autonomic neuropathy. Very bad symptoms, very little can be done. Even after the control of the blood sugars also, these people will persist, these symptoms will persist. But obviously they lose the quality of the life. So the quality of the life is very much disturbed in this autonomic neuropathy population. See the genitourinary, you will have the neurogenic bladder, erectile dysfunction, cystopathy, and retrograde ejaculation. In metabolic, hypoglycemia, unawareness. Again, this is a very, very important in our diabetic individuals. What you mean by hypoglycemia, unawareness? So they don't feel or they don't know, they don't appreciate the hypoglycemia symptoms. So what hypoglycemia symptoms you have? You have tachycardia, you have the perspiration, you have the anxiety, you will have the little headache, restlessness. So all these things are the features of the hypoglycemia. And then they correct the hypoglycemia by themselves. They know that these are all symptoms are because of the hypoglycemia. And then they correct the hypoglycemia by eating something. But what happened when they are unaware of these symptoms? The blood sugars will come down. And then finally, they drop, they fall on the ground. They will have the convulsions. They will have the froth in the mouth. And they will be unconscious. So that is hypoglycemia, unawareness. So this is more dangerous, almost close to the death. So this is all because of the autonomic neuropathy. So autonomic neuropathy is very dangerous. You have the cardiac autonomic neuropathy with the resting tachycardia, postural hypotension, etc. So they will have sudden cardiac death. You will have the gastrointestinal autonomic neuropathy. You will have the vomitings. You have the constipation, the diarrhea, abdominal bloating, abdominal chronic abdominal pain, etc. Very little can be done. You have the genitourinary autonomic neuropathy, especially in the males. You have the erectile dysfunction. You have the retrograde ejaculation, cystopathy. So always burning sensation in the bladder. There will be urgent continence, etc. Neurogenic bladder. And the metabolic, you have the hypoglycemia unawareness, hypoglycemia unresponsiveness. In the cutaneous, you have the distended veins on the foot due to the AV shunting. So if you see the foot of the some chronic diabetics, you have a beautiful vasculature, almost surface anatomy. So these are all because of the distended veins. So this is because of the autonomic neuropathy. So by seeing these things, you should know that this fellow is having autonomic neuropathy, and these autonomic neuropathy are very, very bad patients. They may suddenly go for the sudden cardiac deaths and etc. So there will be the sweating disturbances, areas of symmetrical anhydrosis, and gustatory sweating. And pupillary, you will have Argel-Robertson type pupil and decrease the diameter of the dark adapted pupil. So the diagnosis, symptom profile, neurological examination, quantitative sensory testing, nerve conduction studies, and autonomic function testing quantitative. All patients with diabetes should be screened for distal symmetrical polyneuropathy starting at the diagnosis of the type 2 diabetes and 5 years after the diagnosis of the type 1 diabetes. So usually all these complications from the date of the diagnosis of the type 2 diabetes. But whereas the type 1 diabetes, only after 5 years. So first 5 years of the type 1 diabetes, usually they don't have any complications. Suppose if you contain the blood sugars very effectively in the type 1 diabetes, you may not have these symptoms even after the 10 years, 20 years, 30 years, 40 years of the type 1 diabetes also. So ultimately what is more important is euglycemia. So you have to keep the blood sugars as close as possible to avoid all these complications. Assessment should include a careful history. Okay, the temperature and the pinprick sensation and vibration sensation. Here you have to use the 128 Hz tuning for the pricks 10 grams monofilament. All patients should have an around 10 grams monofilament testing to assess for the feet at risk. See here, this is gloves and stocking areas. Gloves and the stocks. See the 10 grams monofilament, vibration sensation, and then the pin sensation, pin pricks, your needle pin, and then this is the touch with your cotton wool, and then the thermal test, hot water, cold water, etc., and position test. So all within 1 minute we can complete all these things. Okay, with a monofilament, with the tuning fork, and with a cotton wool, and then we with the position sense, so we can see these tests. So most of our representatives, they provide us these monofilaments. So these are the areas where you have to check for that. So it's a simple screening test for diagnosing the patient at risk of the ulcers due to the peripheral sensory polyneuropathy. See the motor neuropathy in the feet. Looking for the wasting of the small muscles and deformities such as the hammer toes. Formal power testing is not useful here. What is the differential diagnosis here? Some people may have the congenital familial, that is Charcot-Marie-Tooth syndrome, very, very rare. Trauma, nowadays very common because of the entrapment syndrome, sarcoidosis, leprosy, etc. Neoplastic, yes. Paraneoplastic syndromes, multiple myeloma, amyloidosis, and metabolic or endocrine, CKD, vitamin B12 deficiency, hypothyroidism. So in all these neuropathies, especially in our areas, so check for vitamin B12, provided if the patient is also a chronic alcoholic. Then rule out the thyroid disorders, especially hypothyroidism. And then urea creatinine electrolytes to rule out the chronic kidney disease. Vasculitis, alcohol, heavy metals. Some people may have the autoimmune diseases like antiphospholipid antibody syndromes. How to diagnose the autonomic neuropathy? 3 tests of the heart rate control, parasympathetic, heart rate variation and the deep breathing, standing, and Valsalva. So in these 3 positions, there will be the change in the heart rate. But in autonomic neuropathy population, even the resting, the same, even after these procedures also will be the same. Again, the BP, the standing, and the sitting. No test was found to be sufficiently standardized for the evaluation of the pseudomotor, gastrointestinal, genitourinary pupillary response in the routine practice. In the same way, in the routine practice, very difficult to diagnose the autonomic neuropathy unless you closely examine the patient and then take the history and the chronicity and then the past history. Then only can identify that the patient is at the autonomic neuropathy or not. So early stage, abnormal to the heart rate response during the deep breathing. Intermediate, abnormal to the Valsalva maneuver. Severe, presence of the postural hypotension. Again, the management, treat the root cause, that is the glycemic control. Symptomatic, agent that restore and improve the nerve function, like your methylcobalamin or vitamin B12 or pregabalin or gabapentin, duloxetine, etc. And avoidance of the neurotoxins, mostly alcohol. Alcohol is a neurotoxin, so alcohol definitely will cause it. Otherwise, your arsenics, some metals, lead, etc. So glycemic control is very important. Painful neuropathy. It is very difficult to manage. No single agent is universally effective. Most patients require the combination therapy. Again, these drugs will have a lot of the side effects, like your pregabalin, gabapentin, etc. They will have the swelling of the feet. They will have the giddiness. They will have the nausea, vomiting, abdominal discomfort, sleep disturbances, nightmares. So these are all very, very difficult to control the neuropathies. Medication should be added in a stepwise manner. Non-pharmacological managements like cold water immersion, electrical stimulation, acupuncture, Chinese, etc. may be of benefit in selected patients. So as I told you that autonomic neuropathy, there is a specific drug, no specific drug. Suppose if the patient has a constipation, use the laxatives. If the patient is having the cystopathy, so self-catheterization. Diarrhea, your anti-motility drugs or your rifaximin. Erectile dysfunction, sildenafil. Gustatory sweatings, a tropical glycopyrrolate. Gastroparesis, your domperidone or ondansetron, etc. So that finishes our neuropathies. Retinopathy and the neuropathy. Retinopathy, so we have to send all our patients on the day 1 of the diagnosis of the type 2 diabetes for the retina examination. And for the neuropathy, so 10 grams monofilament, 120 as a tuning fork, and cotton wool, and pinprick, and your knee jerk to see the ankle jerks, relaxation of the ankle jerks. So these are sufficient to know whether the fellow is in the neuropathy or not. In the same way, examine the thighs for any proximal neuropathy. Examine the eyes for any third nerve palsy or in the drooping or in the sixth nerve palsy, diplopia, and the abduction will be lost. And most of these neuropathies, the treatment is mostly the diabetes management, good glycemic control, and then symptomatic treatment. Okay, so that finishes our microvascular complications.